All right, welcome everyone to this month's AHA team training webinar. Hope everyone's week is going well. We are just about at the halfway point, so congratulations. And welcome everyone to our this month's webinar, which is Flip, Don't Flop, Remodeling Communication Using Deconstructive Feedback. My name is Mithil Patel. I'm a Senior Director with the AHA Center for Health Innovation, and I have the honor and pleasure of serving as your moderator for today's webinar. If we can jump to the second page, we'll get into some logistical items before we get into the meat of our discussion here. A couple different ways to access the audio. If you're struggling with your computer speakers, you can, of course, dial in. That information should be available to you at the bottom of the Zoom toolbar here. And then if you have a question for our presenters, chat those to us using the chat function. And we'll have some time at the end of this discussion to get into Q&A, and we'll try and get through as many questions you have as possible there. On the next page, we have a little bit of information on continuing education credit for those of you who are interested. You do have to create a Duke Link account. It's a one-time thing that you have to do. And then after today's session, you have a day to text SOMGEC to the number that you see there to get your credit, your continuing education credit. So hopefully you guys are all taking advantage of that for those of you that are interested in that. Last comment before we jump in on the next page, just a friendly reminder on our upcoming team training events. We have a couple, we're excited to get back to in-person training. So we have a couple coming up in the month of June, one at Tulane and one at Northwell. We do have some seats available for both master training courses. So if you're looking to refresh or become a master trainer so you can train and disseminate team training best practices at your organizations, those are some great events to either reinforce what you know already or to get started. And then of course, we have our cadence of webinars that are coming up as well that you can see there. All right, let's get into it. I would love to introduce this full team that we have for you all today. You see names and pictures there, but I'll try and be quick. So we have Kendra Duran, Laura Goliath, Jennifer Johnson, and Phyllis Kronk, who are all either instructors and/or professors at Ursuline College, which is part of, and part of that is the Breen School of Nursing. Joined by them is Tyler Reimchisel, and he's part of the Case Western University team. So I'll turn it over to them to walk us through this discussion. So thanks, everyone.
Hi, everyone, and I just want to say welcome to today's presentation. Our objectives today is really to look at how communication affects team processes and outcomes. We're going to compare and contrast, deconstructive, constructive, and deconstructive feedback. So we're also going to be applying the deconstructive approaches to a case study, a challenging clinical scenario. So with that, we will begin our presentation by presenting you the case of Mr. Bob Jones, and it will be presented by our never ready for primetime players.
Hi, good morning. Are you ready to give me a report? Today's my first day on the floor.
Oh, yeah, I'm almost ready. Give me a minute. It's been a really long night. Who do you need to report on?
Looks like Bob Jones is who I need to report on.
Oh boy, good luck with that one. Needy family, let me tell you. Patient's really fine. He came in last night, got some CHF. You should have some IV Lasix coming up to the floor this morning. Really some crackles, some edemas in his assessment. Other than that, he's alert and oriented. He's really fine, doesn't really need anything.
Do you happen to know his vitals or labs?
You know, they're in the chart. I gotta go.
All right, it looks like he has a history of an MI, AFib, CHF. He's on DIG, Lasix, Eliquis. His weight is down 1 pound since last night, pitting edema. His O2's at 2 liters, pulse ox 90. Blood pressure's 140/90, heart rate 70 and irregular, lungs got crackles. Geez, his potassium's only 3. And he's getting Lasix 100 milligrams twice a day. I wonder why nobody bothered to address this. Well, the potassium's probably going to keep going down if we don't do anything about it. I guess I'm in for one of those days. Hi, Dr. Whitecoat. This is Nurse Kendra from 4 North. I'm calling about Bob Jones. I'm preparing some morning medications and need to obtain orders before I can proceed. I'm reviewing his meds and notice he's not on any potassium. He still has some crackles to his bilateral bases and 2+ pitting edema to his lower legs. He reports his breathing is easier and remains on oxygen at 2 liters with a pulse ox of 90. His weight's down 1 pound since yesterday.
Well, why does he need potassium? He has FVE. He needs Lasix. Have you given him the Lasix yet this morning?
No, I haven't. I wanted to talk to you first about the potassium.
He needs Lasix. Please give him what I ordered with the Lasix this morning, then you can give me an update later. I'll see him later this afternoon.
Hey, thanks for answering my questions. This is why I love talking with pharmacy. While I have you on the line, have you talked to Dr. Whitecoat today?
No, why?
Well, I called to talk to him about a hypokalemic patient on Lasix, and he would not give me the potassium order and basically hung up on me.
That's not good. Who's the patient?
Patient is Bob Jones on 4 North.
I can see that he's getting 100 milligrams of IV Lasix twice a day, and his potassium is 3. Yeah, I don't see any potassium ordered.
Yeah, I definitely think that needs to be addressed. I'm concerned about giving the Lasix without any potassium on board. It makes me really uncomfortable since his potassium's only 3. We drew it again this morning and the results are not back yet, but I would expect it to be lower, so this could be a safety issue.
Tell you what, I have to call Dr. Whitecoat anyway. Would you like me to talk to him about this patient?
Oh my God, yes, that would be awesome. Thank you so much.
Happy to help. Take care. Hi, Dr. Whitecoat. This is Pharmacist Johnson. I'm about to send up some meds to 4 North, and I have a question. Do you have a minute?
Sure.
I wanted to ask you about patient Bob Jones. I see that he's still getting IV Lasix 100 milligrams twice a day.
Yes, I'm going to see him later today.
Okay, in the meantime, his potassium is 3, and he doesn't have any potassium ordered. I'm concerned that the lack of potassium is going to worsen the hypokalemia and lead to cardiac dysrhythmia. I recommend starting potassium.
This isn't urgent. I'm going to see him later today.
I understand you'll be seeing him later. In the meantime, he's getting 2 doses of IV Lasix. I think it is urgent that he begin potassium prior to the Lasix.
Well, what was his potassium level when he came in?
Potassium was 4 in the emergency room at the time of admission. Looks like he was on 20 milligrams PO daily along with 20 milliequivalents potassium daily at home. Potassium was 3 when he was admitted to the floor earlier this morning. Last potassium lab is still pending.
Well, I could see him earlier in my rounds.
That's good that you're going to assess him sooner. In the meantime, should we initiate potassium? I can send it up the Lasix. I think this would be the safest option for the patient.
Okay, fine. I'll put in an order for potassium, 40 milliequivalents PO BID.
That sounds like a good plan. So you're going to put in the order for the potassium 40 milliequivalents PO BID now?
Yes, that's correct. I'll put the order in now.
Okay, I'm the risk manager assigned to this case. Listen, I'm just going to say there's a lot going on in the hospital. Hold on one second. I've got to answer this. All right. So we're all here to discuss Mr. Bob Jones. I have here he was admitted 2 days ago through the ER for an acute CHF exacerbation. Last evening, he was admitted to the ICU. with severe hypokalemia and VTAC with a prolonged QT wave. His potassium level was 2.0. So we're all here to discuss the case and look at the root cause analysis. Each of you cared for this patient in the last 24 hours.
I knew it. That's why I called the doctor to get a potassium order. It's in my charting. Look at the charting. It's in the charting. I called the doctor. He wouldn't give me an order. I even told the pharmacist he needed potassium. That's true. I did talk to the doctor, and while he was hesitant to prescribe the potassium, an order was placed. Pharmacy filled the medication and sent it to the floor with the Lasix.
An order?
Is there an order?
I need to finish this.
You know, I put in the order at 11:40 a.m. I don't even know why I'm here. I mean, I spoke to the pharmacist. There is an order.
What order? Nothing was in the EMR when I gave the afternoon dose of Lasix. Nobody said anything to me about an order.
All right, I have some questions. Number one, who updated the nursing staff on the new order for potassium? Number two, when were the new medications entered into the EMR? All right, I need to run. It sounds like we need a lot better communication.
Okay, good afternoon. So welcome to this webinar. I'd like to first of all appreciate all of you for taking time out of your busy schedules to join us. I've really enjoyed the chats that you've shared, and it's great to hear that there were so many people joining us from all around the country as well as around the world. So it's our hope that this will be a great session. I hope that the video was maybe about a situation at an institution near you, but not actually at your institution. But maybe there was some elements of that you could recognize. And we're hoping that through this session, you will be able to learn how to provide more effective feedback using a deconstructive approach, so that when you're in situations similar to what we try to portray in that video, that you will have a way of coming to a more effective resolution when conflict arises. So we'd like to start by talking about what we consider to be effective feedback. And this is based on the articles that are listed below, as well as our own cumulative experience about what we found to be useful when we give feedback. First, it's important that you're identifying the level of learner and their competency level so that our expectations of performance is aligned with what we'd expect. So if they're a first-year health profession student, their level of performance is obviously going to be different than if they are in a residency program or a doctoral program, or if they're a practicing clinician who's finished their training and licensure. Also, effective feedback should guide future learning, and it should frame that in a way that the learner, as well as the person providing the feedback, is reflecting on the situation, and that reflection then leads to ways that they can either improve if they were in a similar situation in the future, or they can identify what they did well and make sure that they do that again in the future. So it's very important that feedback is not the end of the process, but it is a continual process. We're always trying to be better and better in our practice. Feedback should also be well-timed and expected. Ideally, you would want to tell folks at the beginning of an encounter or the beginning of a course or a rotation or whatever the experience is, that they will be getting feedback in the future. That way they know from the very beginning that there will be an assessment that will be provided to them in the future, and they can prepare for that. If you don't set that up, then it's also okay to provide feedback after the encounter or after the educational intervention. But it's important that you make sure the person is ready to receive the feedback. If they're not in a frame of mind, if they're not at a place where they're ready to receive feedback, then it's unlikely that feedback is going to be effective. So I simply say when I'm providing feedback that I'd like to provide feedback. If that's okay, I will frequently say if I've seen somebody do a patient encounter and they're presenting to me and I want to give them feedback about that clinical encounter, I'll just say that I think that there are things that you did well. There may be opportunities for improvement from my perspective, and I'd like to get your thoughts about how you think it went. So I'm framing this to make sure that they are ready to receive it and that we can enter into a dialogue, which we'll say more about when we get to the description of what deconstructive feedback is. It's important that when we're providing feedback, we are using specific performance behaviors and observable data. So we're not generalizing from the past 20 or 30 encounters we've had with that person, or we're not providing feedback that's based on our history. It's based on a specific conversation or encounter or clinical process. And it's important that we're providing feedback on observable data and information, not on our inferences or assumptions about that data. So that leads us to this next bullet point. We want to make sure we're providing feedback on actions and decisions, and that is the focus of the feedback rather than our own inferences, assumed intentions, or interpretations. If we get to a point where we're providing feedback based on inferences or assumptions, then it's important to state that and also state what led us to make those inferences and assumptions so that the person receiving the feedback can critique whether or not those inferences and assumptions are accurate and why we may have drawn inaccurate inferences or assumptions. It identifies and corrects areas for improvement. So we talk about opportunities for improvement, and obviously that's a very important part about feedback is that we want to make sure that we've identified specific areas that could be improved from our perspective. And we could also, through the process of feedback, talk through ways to make it better, make that encounter or that conversation or that work on a project better. And lastly, it's not judgmental or evaluative. So it's very important that we're talking about actions and behaviors, not about an individual person's self-worth or the merit that they have as a student, as a collaborator, or as a fellow clinician. This is why I use the term assessment when I talk about learners, but I talk about evaluating a program. I just avoid using the term evaluating for evaluating a learner because I don't want there to be any sense that I'm putting value on that person. The encounter, the action that I'm providing feedback on is the focus. It is not on the person themselves. So I found it to be very helpful in my work to think about 3 different types of feedback, and these are actually outlined in our objectives. Those are destructive, constructive, and deconstructive. And I'm going to go through each one of these in turn so that you have a good understanding about how these compare and why we would advocate for using the deconstructive approach. So the first one is one you're probably familiar with, and hopefully you have not experienced this too much, but I do feel like this form of feedback is sometimes fairly prevalent in some of the environments where we're working. Destructive feedback can break down the individual. If we say something that is condescending, that is judgmental, that is evaluative, and it leads to someone being shamed or humiliated, then that can break down that individual. But it's also important to recognize that it can break down the team because there are bystanders, there are other members of the team who may hear this, and it can be detrimental to the team itself. And so it's important to avoid using this type of feedback. It's really of no benefit to the learner because they can be harmed by that, and it doesn't foster ongoing learning. I think it includes passive-aggressive comments. So passive-aggressive comments are still aggressive, and they can still be destructive. Sometimes it can also be in the form of questions where we are making a statement by asking a question, and it can be very derogatory and tear the other person down. Examples of these are non-genuine questions. So a genuine question is a term that I learned from Roger Schwartz, who's a team coach, and he defines genuine questions as questions that we honestly don't know the answers to, that lead to a dialogue or a conversation, and they are not suggestive. So a non-genuine question is all of the opposite of that. It's where it's where we make a statement in the form of a question, but it's really more of a statement about our perspective. For example, this could include saying something like, "You didn't really think that was going to work, did you?" Or, "What were you thinking when you took care of the patient in that manner?" Or going back to the video, "I can't believe that the physician didn't just write the order for potassium. Who does he think he is? So it's in the form of a question, but it's not genuine because it's more of a statement of, our perspective than it is a way to try to understand another person's perspective. So in general, non-genuine questions, because of their destructive nature, should be avoided. It's also important to remember these are really never justified. And so I think that we would like to suggest that a better way of doing this is to think about a deconstructive approach. When I do this through a workshop, we actually spend some time collecting feedback from participants, and sometimes they will offer deconstructive comments as a form of feedback. And then during the workshop, we will rewrite them into a deconstructive way. So that's something that you can think about as we're going through this webinar today, is how you may take some of the destructive feedbacks that you've received or that you've heard and convert it into a deconstructive approach. But before we talk about deconstructive, I want to talk about another form of feedback that is actually very commonly advocated. And for reasons that I'll explain, I actually don't find it to be that helpful. Constructive comments or feedback are really meant to build up the other person. So in that sense, that is good. We want to be supportive of our colleagues, our peers, and the individuals that we teach. It does consider the other's interests. And so it has this sense that we really want to help the other person, and we want to make sure that we are considering what's in their best interests. It is certainly often used as we are providing feedback to learners or to our colleagues. And it includes something like unexplained compliments. So in the video you said there was a comment like, I really enjoy working with pharmacists, or I like talking to pharmacists, or great job. So a lot of us would probably be happy if we received those compliments. So that's great. Compliments by themselves are not a problem. It's that compliments, if they just stop at that point, do not foster ongoing learning. A lot of times we give a compliment like great job, or that was a really good presentation, and it's unclear to the person who presented the patient or gave the presentation what was it that was well liked. And so it's important that when you're giving compliments that you explain why it was a great job, what did they do well. A really easy way to do this would simply be to say that I think you did a great job because, and if that is from my perspective. And so that would take a constructive compliment and make it into a deconstructive feedback. One of the problems I have with constructive is it insinuates help. It makes it seem like the person giving the feedback is all-knowing, that they have the full perspective, and that they are wanting to help the other person. But it's unclear if the other person receiving that feedback is in a frame of mind where they can actually receive it, and maybe they don't necessarily feel like the compliment is really helpful. And so that insinuation can be problematic when we're talking about confrontational or situations where there may be differences of opinion. When one person reaches out to try to help, there could be a more fundamental difference of opinion, and that attempt to help the person may actually be misinterpreted and may actually undermine the whole goal of providing the feedback. It frames my perceptions and judgments as facts. So I see something and I'm going to now help you, and I'm going to make sure that you can do a better job. And it's as if, again, I am all knowing that my judgments are unquestionable and are correct. So in situations where we may not value the perspective of the person, where we may have differences of opinion, or where we may not even really want that person to provide us feedback, their comments can actually be perceived as being presumptuous or condescending. And I suspect we've all been in these situations where somebody, out of an attempt to help, actually is insulting or is irritating even. And so for these reasons, I feel like constructive feedback is not as good as deconstructive feedback. So I'd like to explain what this means. First of all, the word means that we're taking the pieces apart. So we used a construction analogy for the title of this webinar, and we really want you to feel like that you are taking apart or disassembling a scenario, an encounter. Maybe you were in a conversation with someone, and what we want you to do is rewind and replay that scenario, that encounter, into its individual parts and make comments about those parts of that scenario. So you're again only going to provide feedback about what was observed and what you could see had someone recorded that encounter. It contextualizes it into that specific encounter, and it doesn't generalize. So for example, you would never say in a deconstructive feedback, you always do that, or you always say those kinds of things. That generalization is now pulling together a lot of historical encounters that you've had with the other person. And it's really unfair because now the person has to try to respond to all of the history that you have with them. It's much more difficult to do that. And it's important to just focus on a specific encounter and contextualize it within that one specific scenario. It also acknowledges many perspectives. So I will frequently say, and I've tried to say during this webinar, from my perspective, this is how I see it. And I specifically say those words. So if I'm giving feedback to a student or a resident or someone that I am supervising, I'll say, here is how I view your performance. I would like to hear how you think you're doing. And this is based on my perception. And I will explain why I think that, but I want you to know it's based on my perspectives. I was teaching this to a group of residents several years ago, and I felt that they had internalized my comments because at the end of the session, they were providing feedback on the session. And one of the residents wrote, based on my perspective, I don't know if it's true. I think you're a pretty good teacher, but again, I don't actually know if that's true. So he actually had internalized the point that he was just saying it from his perspective. And so it's kind of nice that he turned this into a bit of a joke. But I think it is very helpful because when you say it's from your perspective, it welcomes then this idea that we want to hear what the other person is thinking. It's also important that you're focusing on my perspectives and inferences of the facts, not the other person, right? So it's as if you have the scenario, the video that you may have been recorded in your mind's eye, or the data that you're looking at in between the two of you, and you're focusing on that data. You're not focusing on the other person or the person's worth or merit, and they're not focusing on you. You're focusing on the facts. And if you make inferences of the facts, you're specifically stating that. This requires a two-way conversation. If I say, based on my perspective, this is how I think you're doing, how do you think you're doing? You are inviting a conversation. And I think that's a very important aspect to have about feedback because there may be things I need to learn. Maybe I need to learn how to be a better leader or a better supervisor. Maybe I need to figure out how I can be a better team player or provide better care to the patient. And so there are things that the supervisor or the person providing the feedback may also need to learn. And I think this is a great way to create psychological safety within the team or within the dyad that you're providing feedback for so that they can also give you feedback. One of the pushbacks, one of the complaints or concerns I've heard is that when you say things about a two-way conversation, you are implying that it's going to take time. And a lot of people say, we just don't have time to do this. I would say a couple of things about that. First of all, if this is a new approach for feedback for you, it is true that it will take more time because anything that's new that you're trying to practice to get better will take more time. But it doesn't take as much time as you imagine if it becomes part of your routine, if it becomes the way that you approach feedback in general. And so initially, yes, it will take some time, but once you do it enough and you practice it like many other skills, it does become much easier to do and it doesn't take a lot of time. The other thing I would say is instead of thinking about this as a way of wasting time or taking too much time away from what's important, I think of this as investing in the other person, investing in our professional relationship, and investing in our team. And so that investment, this conversation, fostering a place where you can discuss how we can all get better, can actually save time in the long run because it can help avoid conflicts that are difficult in the future. It can help avoid bad practice like was seen in the video. So had they used deconstructive feedback, that last scene where we had to have a risk manager come in and talk to us would have been avoided. So I actually think that this can actually save time in the long run. And then lastly, it may identify more conflict. So if we're in a dialogue And if we haven't addressed conflict with that person in the past, if we haven't provided feedback, you may actually identify more challenges. You may identify more issues that need to be addressed. And I'll give you an example of this. I was meeting with a resident several years ago. He had received several complaints in a written format on his evaluations when he had done rotations that he was condescending and rude. So there were 3 different nurses who had filled out the evaluation forms. They did not have any communication with each other. They were in separate units in the hospital, but they pretty much said the same thing about him. And so he's now having his semi-annual review with me, and we brought this to his attention. And as he read through it and he finished reading it, his response was, and I said, I think now we have 2 issues. One is the pattern of behavior that has been outlined in your written feedback, and you're sitting in my office reading the feedback, and you appear to have some nonverbals that was dismissive. You rolled your eyes, and you didn't appear to take this seriously at all. And so I think we now have 2 issues. And so by using a deconstructive approach and saying, I noticed your nonverbal response to that feedback, it appeared to me to be very dismissive. When you rolled your eyes, that seems like we have a couple of issues. You're not taking this seriously. And when it's being addressed, you're being dismissive, even with the leadership of your program. And so I do want to acknowledge that sometimes this can identify more conflict, but I think, again, if you invest the time and you try to address it, it will save time in the long run, and it's better for your team. So deconstructive feedback is a concept I got from Bob Keegan in his book, How the Way We Talk Can Change the Way We Work. And he writes, having different meanings isn't a problem. We make it a problem when we insist that our meaning is the better one without ever exploring its validity. So I think it's important to say that it isn't that my perspective lacks merit. It's that my perspective is incomplete. And I need to recognize that other people looking in on the same scenario, participating in the same work that I'm participating in, have a different perspective. And this is a way to welcome that. It's a way to acknowledge, not that I may be right or wrong. That's a very simplistic and inaccurate way of viewing it. It's that it's incomplete. And I need to engage in a conversation to see what could make, as we talk through this, a better representation of the situation. And it's also important to recognize that the supervisor or the peer or the person providing the feedback does not have supervision. I have value and merit as a person providing feedback, but it's much more valuable if we can engage into a conversation where we can talk through what is the most appropriate way to think about the scenario. So we're going to go through some of the comments in the videos that were made, and I can just comment about the different forms of feedback that were provided in the video. So the first comment was,
look in the chart. I'm ready to leave.
So this is a very dismissive comment that the nurse made, and was not productive at all, right? It was not providing the best care to the patient. It's data that she should have had available, but it's very dismissive.
I knew it. That's why I asked Dr. Whitecoat for the potassium. Check the charting. It's in the charting. He wouldn't give me an order.
So again, very dismissive, condescending in terms of that's why I asked Dr. Whitecoat for the potassium. And although I think in this video, the nurse is correct, the way she says it is a very destructive way that doesn't build up the individual physician or the team themselves. The next comment that I made was, I put the order in at 11:40 a.m. Why am I here? I talked to the pharmacist. They had the order. So I raised my voice in the video portraying that Dr. Whitecoat. I was very dismissive about the whole situation and undermined it. And I feel like that physician in the video also used his power to dominate that situation and be completely dismissive. So obviously that was not just destructive to the individual sitting there, it was destructive to the whole team. So what about some constructive comments that were made during the video? I said, give the Lasix like ordered and give me an update later. So I was providing very specific guidance about what to do from my perspective, but it was very much a top-down, do what I say, without really engaging in a conversation where we were all equal members of a team. Another comment that the pharmacist made.
That's not good.
So it's a correct statement, but it would be good to say, why was it not good from the pharmacist's perspective?
OMG, yes, that would be awesome.
So similarly, why was it awesome? What was it that the pharmacist was doing to help the nurse so that the nurse could reinforce how important the allyship was that the pharmacist was showing to the nurse?
Who updated the nursing staff of the new order of potassium? When were the new medications entered into the EMR? I need to run, but it sounds like we need better communication.
So again, the risk manager and her expertise is saying we need better communication. She asks important questions, but she leaves. She doesn't even engage in a conversation. And I guarantee that those individuals left at the table are not going to have a productive conversation without her leadership. So good start, but by leaving the conversation, it undermined the potential there for a deconstructive conversation. And there were some deconstructive comments in the video.
I'm concerned about giving this Lasix without any potassium on board. It makes me really uncomfortable since his potassium is only 3.1. I don't want to cause the patient any harm. He's already hypokalemic.
So again, she states her view and she explains the view with details. It's very specific. There's nothing judgmental about the physician or the lack of an order. So I think this is very helpful.
I understand you'll be seeing him later. In the meantime, he's getting 2 doses of IV Lasix. I think it is important that he begin potassium prior to the Lasix.
And again, the pharmacist is stating her views, explaining why she thinks it's important to get the potassium order, and is really persistent with the physician to make sure that he puts the order in, but stating in a way that is voicing her concerns directly to the individual physician about the specific scenario. So what I'd like to do now is go back and replay the last scene where the risk manager is walking us through the debrief of what happened to the patient. So we're going to go back to another video and see what would this look like if the team started to use a deconstructive approach.
Hi, everyone. Hi, I'm the risk manager for this case. And, I just want to start by saying that it's really, really busy in the hospital right now. But this is also very important to the case study that we're going to discuss. So why don't we put away our phones so we can have a good substantive discussion. Thank you. All right, so we are here to discuss Mr. Bob Jones. And from the information that I have, he was admitted 2 days ago through the ER for an acute CHF exacerbation. Last evening, he was admitted back to the ICU with severe hypokalemia and VTAC with a prolonged QT wave. So his potassium level was 2.0 then. We're here so we can discuss the case and look at the root cause analysis. And we're also here so we can better understand in the future and consider any system level issues that may need to be addressed. Each of you cared for Mr. Jones during his stay, so input from each of you is very valuable for this process of looking at the root cause.
Well, I was concerned about his potassium level, and as I recall it, I talked to Dr. Whitecoat about the patient's potassium level and asked for an order for potassium. Dr. Whitecoat, is that how you recall it?
Yeah, I guess I think that's fair. I didn't really feel like I had all the information I needed to put in the potassium order, but once I spoke with the pharmacist and got that additional information, I did put in the order then.
Yes, that's true. I talked to Dr. Whitecoat later that day. While he was hesitant to prescribe the potassium, an order was placed. Pharmacy filled that medication and sent it to the floor with the Lasix. Unfortunately, there was some time that passed between the nurse notifying Dr. Whitecoat and the order being obtained.
So this is really productive because from my perspective as a risk manager, we're honestly discussing the details of the case. Now it looks like we had some challenges in our communication. What could we have done differently to decrease the amount of time that that passed when the patient received the medicine?
Well, thinking back, I could have provided more information to Dr. Whitecoat when I first talked to him by using an SBAR format when we spoke in the morning.
Well, we did not close the loop with the nurse once I received the prescription. The nurse was unaware there was a new med order. I probably needed to do a check back with the nurse.
Yeah, and as I recall, it was a very busy morning for me, and I really did not devote the time and the concentration I should have to this case. And I think if I had done that, I would have put in the order sooner.
So I really appreciate everyone acknowledging opportunities for improvement. I also think it's really, really important to highlight the team. And the team has identified that there's various TeamSTEPPS tools that could and should have been used in the professional communication that went on, especially in the area of SBAR that you've identified, CUS, to challenge rule, and shutback.
Just give me a minute while I bring up the slides again. And we just have a few more slides, and then we're going to open it up for questions. So in that video, we showed what would happen if a team started to use deconstructive feedback. So first of all, they disassembled specific events into observable data around the missed potassium dose, and the risk manager went through specific details. Again, they were contextualizing and not generalizing it. There were no comments about those individuals and their professions, like nurses or doctors or pharmacists always do that or never do that. It also acknowledged many perspectives. So at one point, the nurse said, as I recall it, and then asked the physician, do you recall it the same way, right? So acknowledging that there might have been a mistake and there may be other ways to see that. It seems simple, but I think that in those simple phrases, it's showing that you really do want to engage in a dialogue, and you're not a know-it-all. You're not saying that you have all truth. And so it's coming to this from a place of humility and a place of vulnerability that I think can be very powerful just in those small phrases that are stated. It focuses on the perspectives and inferences of facts, not the other person. So what did you see? What was happening? And if there were any inferences, like the physician said, if I remember right, I was very busy, which to me was, he was just making an excuse, but that's okay. He's getting there. He's trying. But at least he's saying and trying to acknowledge that he too could have done better. It does facilitate a two-way conversation. There was more interactions there. And I think it's also important at the very beginning of that meeting, the risk manager said, this is important. We value your perspectives. You need to be present here in this meeting and not on email and not on your phone. So please put them down, right? That was not rude. It was very direct though. And it was a way of saying, I value each person's perspective, and I want you to speak here, so you need to be here, not just physically, but mentally. And it may identify more conflict. This team is not, we didn't resolve everything in that very quick video, right? And that would be unrealistic, but I think it does get you to the point where each person is acknowledging that there's something they could do better. And once that you start saying that you may have made a mistake, that there's something that you could improve on, I think in many cases, it opens it up for others to say there are things that they could be doing better for the team and for patient care and for the work that the team is doing. So our key takeaways from this is that effective feedback reinforces positive actions, it guides future learning, and it promotes substantive reflection. We believe that deconstructive feedback is the preferred type of feedback because it disassembles the event and promotes the dialogue. Utilizing deconstructive feedback can promote and maintain team synergy and effectiveness. So thank you very much again for attending. I think at this time we can open it up for questions, which our slide is, what questions would you like to hammer out? But I'm going to stop sharing my screen and see if there are questions that we have.
Yeah, I think Tyler and team, thank you for that great presentation. We did have a few questions come in, so I'll do my best to get through all of them here. The first one's a good one. I'm going to read it verbatim. My sense is that constructive feedback is a 101 level TeamSTEPPS skill. Deconstructive feedback seems to be a 201 level, if not a 301 level TeamSTEPPS skill How much success have you had in making habitual the deconstructive feedback approach? Do you know of other institutions teaching this 201/301 level skill?
So I want to just start by again acknowledging Bob Keegan at Harvard University. I attended a couple of his workshops, and I want to give him credit in the work that he's done. And so I have used it for many years, primarily because I was an educator in interprofessional education in a medical school. I worked as a program director and then a vice chair for education. And a lot of my work was around addressing complaints from patients, peers, and I realized that I was just saying things based on my inferences and assumptions instead of just letting the other person explain it from their perspective. And I don't like making mistakes. So I wanted to just start the conversation and hear their perspective, because a lot of times I went into those meetings with inferences and assumptions that turned out to be incomplete. And so I have found it to be very, very helpful. I use it all the time now, because I realize that I really believe when I say my perspective is incomplete. It doesn't mean I'm wrong. And I'm usually never 100% wrong, because we're never 100% wrong. We're just never 100% right. And I think it's a mindset of how do you come into these conversations, whether it's I'm dealing with a conflict I have with somebody else, or I'm helping to mediate conflict. In terms of so I do think this is more advanced. And I really feel like people are focusing on constructive, but that puts a lot of burden on the person providing the feedback to have it all right. And I feel like a better way is just to engage in a conversation. And if you, by saying this is my view, it may be wrong, but you're just saying it's my view. And I think it's much easier to start a conversation instead of saying I have to be all knowing. I don't know of other organizations that are doing this. I'm sure that there are. I'm just not aware of it, but I can say that it's something that I've taught a lot, and I've really found it to be very effective. And I would just say that it's worth the practice of trying to get it right, because the other ways that we provide feedback, I think sometimes are very detrimental.
All right, well, we can move on in questions here. So a couple that I'll try and combine around working with leaders and leadership. There's a good one here on new leaders. So how can I work with a peer who's a relatively new leader in my organization that feels like they might be giving homework or assigning tasks versus serving the team's success? So how do you work with a peer that might not be with this lingo and this approach, and kind of help them along so they don't feel like they're just professors assigning homework, but trying to do initiatives and assign tasks that are betterment for the team and patient outcomes?
I think it's a really good question. I think that in my experience, people who are in new leadership roles are usually at a place, hopefully, if they're in a new leadership role, where they're open to feedback. They crave it. They recognize that the responsibilities may be above them. It's a stretch for them. So I think it's an ideal time that if they're in that situation to offer from your perspective what you think would help them be a more effective leader for the team. But I still think you need to check and say, would you be open for me to provide that feedback? And if they are, then you can just share what you think would be better, so that instead of what it sounds like from the question is very top down, like just do this, do that, they're not really leading from behind, or they're not developing more of a shared leadership model. And that may be the perspective that you want to provide, but you have to make sure that the leader is willing to receive it. Let's say that the leader isn't willing to receive it, because I think that that's certainly possible. They may feel like you are confronting them. They may feel insecure, and then they get defensive from their insecurity. What I think is helpful is maybe just to use yourself as an example and say, if this is my leader, and say, you know, what would help me on this team is if you would give me feedback, and I would like you to use a deconstructive approach, use specifics. So you're kind of like coaching them, you're coaching up almost, saying, here's what would help me. It's great that you think I'm doing a good job, but if you could give me specifics, if you could say how I could be a better team member. So you're basically using their feedback to you, but you're asking them to give it to you in a deconstructive way. Then maybe they'll start thinking, wow, if I do that for Tyler, maybe I could do that for other members of the team. So you're not maybe it's a little too sly, I don't know, but I do think it's helpful. You're almost coaching them based on what would help you. And I also think that getting deconstructive feedback is a great way to receive feedback.
Just to kind of build on that question, Tyler, the other kind of theme of questions we're getting here is not so much with leaders, but with staff or individuals that just right away shut down or get defensive. What's your approach with staff? Does your response there or your strategy change at all?
So in the situation where, let's say I'm trying to provide feedback and they're shutting down, is that what you're saying?
Correct. So
I think that it's important, again, to make sure that you can have that conversation, and the person may not be really ready for it, right? So let's say you've prepped them for this. Maybe it's in an annual review or a semi-annual review. So in that setting, hopefully they are ready to receive it, but I would still verify. If somebody gets defensive, I think it depends on what the situation is. If it's possible, you may want to just not have the conversation that day. You may just need to, because if they're not ready to receive it, then it's probably not going to be worth your while. It may just be detrimental. On the other hand, and then I would say though that it's not that they get out of it completely. It's that maybe you just don't have it that day. And so you then focus on more of the process of when you're going to have the feedback instead of the feedback itself. So say, okay, if now is not a good time to discuss this, when could we discuss it? Right? Because it's important that we discuss it. So they may need a little bit of space. Bob Keegan talks about knock before entering. So make sure that before you go into this conversation, they're willing to know that you're coming in to provide feedback. I think sometimes people are aggressive in their nonverbals. And I gave the example of the resident who was, rolled his eyes, and it's a true story, and just sort of crossed his arms. Definitely in those situations, I verbally state what I see. So I noticed that when I addressed this with you, you raised your voice and started using short sentences and folded your arms. To me, that appears like you're being defensive. So I put it into words and I just stop and see what the response is, because in some situations, they can't simply get out of the situation, right? So if you can reschedule it, that'd be great, but sometimes you can't. You need to address it. And if they're using nonverbals, I just put it in verbally. And I do this, I don't do this a lot anymore because people kind of now, I think, know if they're interacting with me that we're going to have this conversation, but it's going to be respectful and I want to listen to you. I want to engage in the dialogue, but trying to shut it down is not going to be effective. The other thing is that I coach people because I do a lot around hierarchies and power differentials. And if you may have to get someone else to help. You may need a supervisor to help. And in that case, again, in full transparency, you need to tell the other person, I don't feel like this is a productive use of our time, but I still feel this is important. I'm going to talk to our supervisor and give them I don't think you can go to the supervisor without telling them directly. I'm going to go to the person I have the conflict with or the issue with. I'm going to give them an opportunity and give them an opportunity to explain it from their perspective and to educate me. I may be wrong, and that happens sometimes. But then after that, if that's still not productive, then I think we need to escalate it. But I tell them that that's going to happen. So I don't know if that answered the question fully. It's really difficult. I feel like I don't want to, I'm talking a lot through this webinar. I don't want it to sound like it gets easy. I don't think it ever gets, we don't want it to be formulaic. It's still very challenging. I don't like people who are aggressive at me and defensive, but I feel like for the sake of the team and for the sake of our professional relationship, we have to lean into the conflict. And I feel this is a really good way of doing it that's very professional.
Thank you for that, Tyler. A couple more questions coming in here. Switching gears a little bit, more so with working with patients. There's a question here. How can this be used to teach clinical staff how to help patients create SMART goals? So I'm sure you know what SMART goals are. So
yes, I'm really glad that someone asked about patients, because I use this when I'm interacting with patients, not even around confrontational or conflicts or anything like that, just how I communicate with patients. You disassemble what the plan is in English so they can understand it, or whatever language that you're practicing in. It's not medical terminology. And I think it can be very effective. Part of SMART goals is that they are specific and they're measurable. And so I think this aligns beautifully with how we write SMART goals. And so not only is this a good way of helping us as healthcare professionals provide care to patients, I do think it can be a good way of explaining to patients how we want them to set up their own goals. And again, that probably is going to take a conversation, a dialogue. And so this can be a good way to start that conversation.
I think we got one more question here. So your videos are definitely trending on the chat here and in the Zoom chat, which has been great. Many of our audience knows the significance of the penguin. Love how you guys work that in here, but some don't. So I think for the benefit for all of us, it would be helpful for us to understand who's the penguin, why was that penguin worked into the great editing of that video.
Yeah.
Awesome. So, and thanks to, I think, Joe and Julia for input on that. The penguin is the mascot for the TeamSTEPPS program based on John Cotter's book, Iceberg is Melting, which is the theoretical framework from which we build, from creating a sense of urgency to getting there where we need to be in implementing more effective team training tools. So it's a bit of levity, if you will, but there's also some hard objective fact behind it, in the fact that penguins must perform effectively in teams to survive. So it's all in jest, yet it really does mean something. So I know the team here, it is a bit of levity, and we don't want to lose that from the penguins. But also, to Julia's point, it's extremely important, John Cutter's work on that and how to build the team and create the urgency needed to start that process. So thank you so much, Natal, for that question and those about the penguins.
Great. Well, I think we can wrap up. So thanks for that, Laura and team. Wonderful presentation today. A lot of insights and information for all of us to walk away with. That's going to wrap it up for us, folks. A couple quick reminders before we break. The slides are in the chat, so you should have access to those. The recording will be made available once that's complete and finalized. A reminder again to sign up and register for your continuing education credit if that's something that you need. Kara will drop that in the chat again as well. And please do find us here at AHA Team Training if you have any questions or concerns. But until we'll talk to you again at the next event. So I think we'll give a couple minutes back here to everyone. Enjoy the rest of your day and week. I hope everyone has a good one. Bye-bye.